Many orthopedic traumatologists recognized early on that osteoporosis and poor bone health have devastating impacts on patients. Today, this is increasingly clear to spine, total joint, and even sports medicine orthopedic surgeons, all of whom are seeing increasing numbers of complications, including periprosthetic fractures and insufficiency fractures. That's why we're convening some of the leading voices in the bone health world to talk to orthopedists and their teams about the rationale for the orthopedic surgeons' growing interest in bone health, including tips and tricks for getting bone health programs integrated into practice and the evidence behind it all. I'm Andrea Spiker, a sports medicine and hip preservation surgeon at the University of Wisconsin, and I'll be your host for a special news series of the AOA Lessons in Orthopedic Leadership podcast called Fixated on Bone, which is brought to you by the AOA's Own the Bone program. So I'd like to welcome our two esteemed guests to today's podcast, Dr. Marc Swiontkowski and Dr. Kyle Jeray. Dr. Marc Swiontkowski is a professor and former department chair at the University of Minnesota. He is a trauma orthopedic surgeon and was president-elect of the AOA at the time of the founding of the Own the Bone program. Dr. Kyle Jeray is chair of the Department of Orthopedic Surgery at the University of South Carolina. Dr. Jeray is a trauma orthopedic surgeon and was Own the Bone committee chair for a couple of terms and is currently president of the AOA. So first, I would like to welcome both Dr. Swiontkowski and Jeray for being the very first guests on our special podcast series. Dr. Swiontkowski and Dr. Jeray, if you can please start our conversation by giving the listeners a little bit of information about who you are and what your practices are. Dr. Swiontkowski, would you mind starting?
No, I don't mind at all. And thanks very much for the invitation. I am in the winding down phase of a career. I've been an orthopedic trauma surgeon my whole career, starting at the completion of my residency in 1984. Generally worked at level one trauma centers, and in the year 2005, when I was department chair at the University of Minnesota, we opened a large outpatient orthopedic center that has a service called the Acute Injury Clinic that now serves over 200 patients a day that come in with musculoskeletal complaints, and a certain number of those will have fractures. And I'm basically working at that center, fixing tibial plateaus and proximal humerus fractures, ankles, etc., many of whom are related to osteoporosis. So that's what I'm doing today, and I'm actually in my final year of surgery after quite a long time.
Well, congratulations on reaching that milestone. Dr. Jeray, can you tell us a little bit more about yourself and your practice?
Sure. So I've been practicing at the University of South Carolina in Greenville since graduating residency and fellowship back in the late 1990s. So I've remained at the same place for a very long time. And as an orthopedic traumatologist, I started seeing our older patients come back with recurrent fractures and started to recognize that there is a problem that we're not really addressing. And as a young orthopedist, I learned a lot from Dr. Swiontkowski when he started that program in 2008 with his sort of what I consider a landmark article that really drove me to create an osteoporotic program at our institution, which we started in 2009. And so that's really how I got interested in bone health. And as a traumatologist, seeing these fractures over and over, I got involved in the AOA. And at some point, I was lucky enough to run the committee for two different terms, and have really gotten to know Dr. Swiontkowski, and he's been, I think, a true inspiration for me and has really helped drive me with my interest in bone health for the last 20 plus years.
Excellent. Thank you. And I would like to ask Dr. Jeray, for the listeners who may not be familiar with the Own the Bone program, can you briefly describe what the current state of the Own the Bone program is?
Well, you'll hear a little bit of the history, I think, from Marc, and so I'm not going to spoil that. But where we are today is a long way from where we started back in 2008. So if you can imagine not quite 20 years yet, we have continued to grow this program to more than 325 sites across the country, with tens of thousands of patients in our database. And the whole philosophy behind Own the Bone really was to recognize that not just taking care of fractures is what we do as orthopedic surgeons, but we need to understand that there's a reason behind a lot of these fractures, especially in our patients that have bone health problems. And for on the bone, it's osteoporosis. That really was the driver. And you kind of heard where we're at now, and we're continuing to grow, and we continue to uh, spread the word of the importance of managing bone health as an underlying reason for fracture. You had mentioned briefly about spine and fractures. So we think trauma and we think total joints. But there's also now we're recognizing it's the shoulder and elbow that have a lot of fractures that we see. It's our ankle fractures for our foot and ankle docs, and it's our wrist fractures in our hand. And we learned a lot of that through our registry over the years with our Own the Bone program. So it affects all walks of orthopedic surgery, and I think we have really spent a lot of time and energy trying to develop the program and make it better.
Fantastic. Thank you very much. Dr. Swiontkowski, can you tell us the story about how AOA came to start the Own the Bone program?
Yeah, I'd be happy to, within the limits of my memory, which is actually pretty good on this topic. So I was very privileged to be nominated and elected into the presidential line. And at the time, one of the biggest topics was the fact that we were being approached by outside organizations that were very much interested in bone health. Um, and there were several organizations that had tried to address this problem of identifying patients with osteoporosis based on the first fracture and getting them appropriate diagnosis and treatment. And we received communication from these groups, and the Association of Bone and Mineral Research, etc., other groups. There was an earlier attempt by the American Academy of Orthopedic Surgeons that was led by Dr. Laura Tosi, who was very critical in bringing this issue to the AOA, a long-term AOA member. And it failed. There was not much interest on the part of Academy members to work to identify these patients at the time of treatment. And so that program failed after a couple of attempts. So we had the issues of other organizations approaching us, other failed attempt in our major orthopedic organization. And the whole question was, should AOA get involved with a clinical issue? The AOA historically, as the oldest orthopedic association in the world, had never really collectively, and still to this day, it's the only clinical problem that we have focused attention on because our identity is a leadership organization, and this was going to be a massive undertaking that was going to take on orthopedic, it was going to require orthopedic leadership to be successful. So after a lot of debate, Dr. Ed Hanley was the president of the organization. Dr. Terry Light was behind me in the presidential line. A lot of deliberation. How are we going to pay for it? We found out that there was some interest on the part of industry, the groups that were manufacturing drugs that can help to limit risk of fracture. So we set out to organize a program. I was asked to lead the effort because I spoke earlier about the center that we built, and that was done in collaboration with a community-based uh, specialty, not a specialty group, a health systems organization called Park Nicollet. And one of the rheumatologists there was a world-renowned osteoporosis researcher named John Scousbow. I also, in the University of Minnesota, we had Dr. Chris Ensrud, who was at the VA here in Minneapolis. These are individuals that have been responsible for developing treatments for osteoporosis. And they, particularly Dr. Scousbo, had attempted to organize a program at the Methodist Hospital in the Park Nicollet system, and it failed because the orthopedic surgeons didn't really buy into the program and work collaboratively to help identify these patients. So I had these experts, and together working with them and a couple of other experts, we had a very interested member of the AOA named Andy Bunta that Kyle worked with very well, his predecessor as chair of the Own the Bone Committee. And Andy had experts and was known nationally as being an orthopedic surgeon interested in the problem. So we developed a intervention that was 8 simple clinical items that we would collect, and then a patient instruction module, and a follow-up module. And then we recruited 8 centers that agreed to participate in this program to collect that 8-item interest and then look at how many of those patients, generally inpatients admitted with fragility fractures, actually received appropriate diagnosis and treatment after their hip fracture, generally hip fracture patients, were appropriately treated. And then we put the intervention in place and then studied it for another 2 years. And the intervention was greatly successful in improving the appropriate diagnosis and treatment. And that's what really led us to move full being into this whole program as an organization. And I believe the committee started shortly thereafter. And Andy Bunta was the first chair, followed by Dr. Jeray. And as you heard Dr. Jeray outline earlier, it's been wildly successful. We are not as successful as we'd hoped we would be, but we have made a difference in this clinical problem.
Well, thank you for that wonderful history. And it was around that time that I believe the Surgeon General had mentioned that bone health was an epidemic in our nation. And so I think you describe AOA as an orthopedic leadership group, really stepping up to the plate and taking care of this.
Attempting to take care of us. We have work to do.
It's an ongoing process.
Thank
Absolutely.
you.
Well, and that leads right into my next question. So fast forward about 20 years later, Dr. Jeray, you're now the current president of the AOA. And in your presidential address this year, you highlighted Own the Bone as something that connects kindness and humility in leadership. Can you speak to us about that?
Well, I think it's very important for us to take ownership about taking care of our patients. And a big part of that is recognizing the underlying problems. Too often we see a broken bone, we don't associate it with a patient. We think that it's something that we have to fix, and we do, but we really forget about the fact that there's other problems associated with it. And the burden of the disease and the quality of life that it impacts these patients is huge. And really, if you recognize that and understand that, I mean, that's really the part about the kindness and trying to respect and appreciate your patients and make them better, but not just by fixing the fracture, but understanding the problem they have that's underlying and preventing those additional fractures in the future.
And for the listeners who would like to see the text of Dr. Jeray's presidential address, this can be found online on the JBJS Orthopedic Forum. Now, Dr. Jeray, how have you seen the Own the Bone program and movement spread across orthopedic specialties and generations?
Well, I think it's really been quite remarkable. I mean, as Mark and I just mentioned, we'd love to see it grow more, and we'd like to see it bigger than it is. But if you consider that in 2008, we started out with almost nothing, a good example would be heart attacks and beta blockers. Uh, when they recognized that beta blockers can change heart attacks for patients in the cardiology world, it took them more than 20 years to make a difference for it to become routine. And so we're not even at that 20-year mark yet, and we've made a huge dent in orthopedics. And I think what's equally important is not just with the trauma doctors, but I think we're getting the hand surgeons to recognize it, the foot and ankle, the shoulder surgeons, the spine surgeons, and we're not recognizing it only for preventing fractures, but we're also realizing that there's some benefit to maybe improving bone quality before you do a spine fusion, maybe improving that bone quality before you do a press fit hip replacement, for example. So it's important, and not just for fracture care and orthopedics. And that's something that's newer and it's more progressive, but we're slowly seeing that as we understand more about this, we can make a difference, not just with fractures, but our patients and a whole lot of other areas in orthopedics.
Yeah, and I think one component that's very central to my own practice in sports medicine, as we see master athletes, aging athletes, we are also seeing more and more bone health related issues in sports medicine as well.
It's definitely not just related to women, and that's something that people forget, but men have osteoporosis as well.
Absolutely.
I
Now,
would just like to highlight, if I may, that we talked about people that have chaired the On the Bone Committee. Dr. Paul Anderson, your colleague in Madison, I think deserves a lot of credit for bringing these other areas to our attention of how assessing patients in joint replacement, and spine surgery, etc., can be a really important advance. So Dr. Anderson deserves a lot of credit.
I completely agree
Absolutely.
with you.
Mm.
Now, for either Dr. Swiontkowski or Dr. Jeray, how would you say the Own the Bone movement has affected orthopedic resident training over the years?
Mark, you
Well,
want to start? Go ahead.
sure. Yeah, I would say that beyond any shadow of a doubt, orthopedic residents today are more familiar with the importance of diagnosing the condition, are more familiar with the pharmacologic interventions, are more familiar with other preventative strategies like rehabilitation for balance improvement, resistance training, etc., than we were teaching them in 2008. There's no doubt in my mind. And most residents have examples of fragility fracture treatment programs in their centers. I would say the vast majority, I would guess at least 80% of residents are exposed to these programs in their centers.
And if you think about that, there was none of that exposure prior to probably 2008 for most centers across the country. And it's sort of a grassroots effort, right? You try to teach the young people the importance of bone health, and then they continue to learn through their residency. When they get out, they propagate that same thing to their partners in different centers, and you hope that it kind of acts like a tumbleweed and continues to uh, attract more and more traction. And that's really what it's done. And we've even tried to do that beyond the residents, and looking at the American Board of Orthopedic Surgery and the opportunities there for making sure the questions related to bone health come on part one and part two. And when we're doing oral exams, we emphasize the importance of bone health to our uh, candidates that are taking the oral exam. And you can see the change over the years. I mean, Mark's been an oral examiner. This has become really part of what they understand is important when they're taking care of these patients. And I think for me, that's really enlightening and something that we should be proud of. And the AOA as a leadership role has really helped progress that, I think, throughout the programs like Mark had mentioned.
And I think this reflects back to your comment, Dr. Drury, about approaching the patient in a more holistic manner. So each of those things that we are now looking at in residency training that Dr. Swiontkowski mentioned really do look at more than just the fracture, which is admirable. Now, for both of you, why do you think that the Own the Bone movement remains relevant for AOA members and for orthopedic leaders in all subspecialties?
Well, it's absolutely relevant, and it's a true core issue with professionalism. If we are not to be perceived as technicians, as people that only want to do procedures, if we are to be perceived as physician surgeons, um, people that want to treat the whole patient, including prevention, um, it matters that we show leadership and emphasize in our centers. We're not just bone broke me fix kind of people. We're thoughtful people that would prefer to prevent an injury rather than treat one. So it's just a part of the oath that we all took when becoming physicians to care about the whole patient.
Yeah, I couldn't have said it any better. It's definitely professionalism, and it's what, sets us apart when we are taking care of our patients. And I think one of the things that we've noticed is just like I mentioned with beta blockers and heart attacks. We tried for a long time to get primary care to be interested in bone health. And not to say that there isn't some interest in endocrinologists, but across the country, we're the ones that see these injuries or we see these patients that are at risk. So we have the best opportunity to make a difference, I think. And so that's why I think you've seen a lot of this gravitate more towards orthopedic surgeons. And a lot of us have established our own programs, usually with the aid of our primary care people. But oftentimes it's the orthopedist that's really running these programs. And I think it's a big part about having leadership in this area and being professional.
And I agree, having all of this come from an orthopedic leadership organization such as the AOA may be one of the reasons we've seen such incredible strides in a relatively short period of time. So congratulations to both of you and to everyone who has put a lot of hard work and effort into this program. Now, can you talk a little bit next about your hopes for the Own the Bone program moving forward into the future?
I would say my hope comes from a realization that occurred in our own center, probably in 2012, 2013, that the patients that we were seeing with hip fractures, we saw 10 years earlier with a distal radius fracture. I remember a day in clinic when I saw three post-op hip fracture patients, and looking through their medical record, they've been treated 8 to 10 years earlier with a distal radius fracture. And my hope is that we can really move the whole program more towards the patients being treated as an outpatient, where it's a little bit harder to identify because the numbers are greater, the clinics are busy, there's not as much time individually with a patient as you have when they're an inpatient, but the bang for the buck is much, much greater if you catch them with the first fracture rather than the second or the third.
Yeah, I mean, I definitely agree. And what I'd like to see Own the Bone, or at least some version of bone health in every program in the United States and internationally. I mean, I think that's a lofty goal, but I mean, I think that's where we need to be when we treat these patients. And doing a lot of traveling as president of the AOA, I see the same problem in the rest of the world. Australia is no better. They struggle with treatment for patients with osteoporosis that present with fractures. About 1 in 5 are only being treated, very similar to what we see in the United States. And it's not just Australia. So it's an international problem. And I think a lofty goal would be able to say that, the AOA has made a difference across the world in bone health.
So when you meet an orthopedic surgeon who still doesn't buy in to orthopedists' role in post-fracture care, what do you tell them to try to convince them to see the light?
Yeah, I ask them, what's the excuse? And when they give me the usual, I'm too busy, uh, I explain how they can create a program that others in their work environment can help to identify these patients, and that all they have to do is support them. There are lots of people that they work with that would love to take on the problem. And so a little shame goes a long way. I'm not sure how effective it is, but um, that's the approach that I've been using.
Yeah, I mean, you have to have a site champion at each center, and you really need to push it with your partners. And what I find to really help be successful is that if you can get the residents on board and they're usually a little easier to get on board because as attendings, we tend to have just a little bit more power over them. And you get your nursing staff and you get your APPs on board. Uh, your partners start to feel a little shamed, and they recognize that this is a true problem, and that they're being a bit selfish if they're not recognizing it and wanting to at least help in part to try to manage it. We've set up a framework around where they can do it. They don't have a lot of excuses, and so I think that helps a good bit.
And I think for those busy orthopedic surgeons, the fact that the AOA and the On the Bone program has done such an amazing job of making it easy for them is incredibly helpful as well. So great resources available at the AOA and On the Bone program websites as well.
Yeah, in a time when it's hard to get anybody on the phone and talk to someone, a person, still with the AOA and On the Bone, if you have issues, comments, questions, problems, if you call, a person will actually answer the phone and will talk to you about your problems and help you. And that's really something that's nice to see that we still do. And we often have lots of centers that are very anxious and willing to allow you to come visit and see the different programs and the way we've established them. And it's a little different everywhere. And so you just need to find some places that may be very similar to you. And our staff here On the Bone can do that.
Well, as
And I
we
would say, sorry for interrupting, but I would say that one of the excuses has been historically that it will cost resources and it doesn't pay. And I will give Kyle a lot of credit for creating a committee environment where best practices are shared from all over, from multiple perspectives, from the DEXA scanning perspective, from the coding and billing perspective, and it's resulted in a real deep source of potential ways to make it so these programs can pay for themselves, which has been one of the concerns that you hear quite often.
excellent points. As we conclude our conversation today, do you have any final thoughts related to the On the Bone program that you want to leave our listeners with?
I
Get,
would just go ahead, Mark, please.
I would say get involved and do the right thing for your patients. Stop making excuses. You're not too busy to do what's important, and that's take care of your patients.
I agree. I couldn't have said it any better. Just do the right thing.
Excellent. Well, Dr. Swiontkowski and Dr. Jeray, thank you both so much for being our inaugural guests on the Fixated on Bone podcast. It's been an honor having you both, and I want to thank you for your tireless and critical work for the On the Bone program. And I look forward to more to come with this program as well.
Thank you very much. Thank you, Mark. It's always
Thanks.
good to talk with you.
It's great to see you, Kyle, and thanks for the invitation.
Thank you for joining us, and we hope you'll tune in to our next episode of the AOA On the Bones Fixated on Bone podcast.